And it's my pleasure to introduce Regina Swift, who I've known for about 25 years. I think Regina has seen more myeloma patients as a nurse than any nurse in the world, literally. And many of you know how dedicated she is. And she's very knowledgeable, she's very hands-on, and she's going to talk to us about supportive care for patients with multiple myeloma.
Good afternoon, everyone. Thank you so much. And I thank the organizers for giving me the opportunity to speak with you today. So in speaking about supportive care for myeloma patients, let me get my slide here. I first have the question, how many of you at the time you were diagnosed with myeloma had bone pain, low blood counts, impaired kidney function, some or all of the above? All right, so 50% say that they've had some or all of the above, which is not uncommon. And so, as you've heard the physicians before me speak, some of the effects of myeloma are that we have low blood counts, we can have impaired or decreased kidney function, and we can also have bone damage. So we'll talk about the bone damage first. Unfortunately, about 85% of patients with multiple myeloma have some type of bone involvement. There's weakened bones, which is due to lesions or holes in the bones. They can have increased calcium because as the bones are breaking down, 90% of our calcium is stored in our bones. So unfortunately, then the calcium is released into our systems, and the high calcium can also affect our kidneys. And also, we can have fractures, whether those be fractures of a specific bone or the spinal column, a vertebral compression fracture. And these can also lead to cord compression, unfortunately. So one of the treatments for bone involvement is bisphosphonates. And what do the bisphosphonates do? Well, they help to build up and protect what bone is left. And they also help to decrease pain by strengthening the bones, so then the bones don't have as much pressure put on them, so that there's more support to the bones. The bisphosphonates that we use routinely are either Zometa or Iridia, and those are both given as IV infusions in your physician's office. The Zometa is usually a 15 to 30-minute infusion, and the Iridia is usually a 2-hour infusion. But the side effects of bisphosphonates are that they can have reduced kidney function, particularly with prolonged use. There can be fractures of the femurs or sometimes of the metatarsals, the toes and bones in your feet. And unfortunately, one of the more serious complications is osteonecrosis of the jaw. So for the most serious complication, or one of the more serious complications of O&J, we make several recommendations. And the first one is, before you start a bisphosphonate, you should make sure that you get a complete, thorough dental exam and have any dental work that needs to be done prior to the start of bisphosphonate therapy. The other is that you practice good oral hygiene and schedule regular dental visits to make sure that your dentist knows that you're on a bisphosphonate. So once you do start that therapy, make sure your dentist is aware of it. And if you need any dental work done, that you keep your oncologist informed as well as the dentist, so that they can work in collaboration, because if there's any extensive work that needs to be done, like a tooth extraction, we would recommend that bisphosphonates be held for at least 90 days before and after the completion of the work. We recommend that you avoid dental implants, and again, be attentive. If something's going on and doesn't feel right, make sure that you're bringing it to the attention of your oncologist and or going to see your dentist to evaluate that there's not the start of an O&J. There's another drug that's been considered for use in the bones, which is a drug called Xgeva. There had been a study comparing this drug against zoledronic acid or Zometa, and the study results showed that there was really no difference between the amount of percentage of skeletal-related events times to skeletal-related events or overall survival. So when we have vertebral compression fractures, a lot of times we have a lot of pain that's associated because of the fact that the compression fracture in the spine is bone on bone. And there's two procedures that can be done called vertebroplasty and kyphoplasty that help to stabilize the bone. And basically, they're outpatient, minimally invasive procedures, and they can basically be done with improvement in the pain. And the procedure is basically that they make a small incision. A needle is inserted with a balloon on the end of it. They inflate the balloon, and they then install a cement into the balloon to then stabilize and restore height to the spinal column. And by doing so, you now no longer have bone on bone, so you have improvement in the pain. And usually that can be seen with significant improvement and, again, restore some of your height. One therapy for pain management associated with bone involvement is radiation therapy. We don't recommend a lot of radiation therapy, and so we kind of reserve the radiation therapy for severe cases of pain management because of the fact that when you radiate the bone, then that part of the bone marrow won't recover, and so then you lose some of your blood cell production. So the effects of myeloma is regarding low blood counts. When you have low red blood cells, it's called anemia. When you have low white blood cells, it can be called neutropenia, and that is when you're at risk for infection. And the infection is what we're most concerned about in myeloma patients. Also, low platelets is also known as thrombocytopenia, and that actually leaves you with a higher risk of bleeding. So another question, which is a typical symptom associated with low red blood counts or anemia? Is it fatigue, easy bruising and easy bleeding, frequent infections, or bone pain? Okay, fatigue. And that is our most difficult problem with multiple myeloma, is treating and managing the fatigue. And sometimes that fatigue is because of low red blood cells. And sometimes those low red blood cells are 90% of the time due to the disease itself, because the bone marrow is packed with myeloma and isn't producing the blood cells that we need. Some of the symptoms can be fatigue, depression, shortness of breath, nausea, dizziness, rapid heartbeat. However, there sometimes are some other causes for which we have anemia, which can be due to iron deficiency or low vitamin B12. So you need to at least be tested that there's not an additional underlying cause besides the disease that could be contributing to the anemia. Once you identify the cause of the anemia, besides treating the multiple myeloma, once the disease gets under control, the anemia should improve. Also, you can sometimes take medications such as drugs such as Epogen, which is a shot that can help produce the production of red blood cells. And you can occasionally have to actually resort to having a blood transfusion so that you can keep enough blood circulating in the system, because if your blood counts get too low, that obviously affects the heart's capability to circulate blood. Neutropenia is when you have low white blood cells. And the risk of neutropenia is infection. And infection, when it's severe enough, can be fatal. So we obviously recommend that you do some preventive things, such as making sure you get a pneumovac shot, making sure you get your flu shots yearly. In some cases, depending upon the treatments that you're on, you may want to take some prophylaxis medications, such as acyclovir, to prevent herpes or the shingles. And also, you may need to take some medications to actually stimulate the production of the white blood cells, medications such as Neupogen, Granix, Zarcio, in order to, and then if you do get an infection, obviously we need to treat the infection with antibiotics or antifungal, depending on the type of infection. So, thrombocytopenia, as we said, is low platelet counts. And the risk of low platelet counts is that you can have easy bruising and excessive bleeding, prolonged time for the bleeding to stop. You can have nosebleeds, you could have some blood in your urine or stool. And if any of those are occurring, you need to let your physician know that, because especially if they're not resolved in a timely fashion, you can result in some serious complications. You may also have low platelets due to other causes, such as a hepatitis or a viral infection. You could have some medication-induced. We had a patient who had had a severe case of the shingles, and she had received numerous spouts of valacyclovir, and the valacyclovir then triggered an immune response to which she developed low platelets, to which she's still being treated for at this time. Once you identify the cause, besides treating the multiple myeloma, you may require platelet transfusions in order to support you through the treatment. But you do need to also hold any anticoagulations that you might have. So any baby aspirins, or if you take warfarin or Xarelto or Pradaxa, you may need to hold those medications. So another question, which of the following can worsen kidney function? Low fluid intake, nonsteroidal anti-inflammatory drugs, hypertension, or all of the above? Very good, all of the above. So let's talk about kidney function. How do you detect poor kidney function? Well, sometimes you as the patient will notice it yourself. You're just not urinating as much as you used to, or that there's almost no urine output. In other cases, it's just simply that we see that your creatinine levels are rising in your blood works when we do the blood works on a regular basis. The problem with kidney function is that it's a vital part that we need, so we don't want that kidney function to occur, or decrease in kidney function to occur. So we need to also know that there's other causes for kidney dysfunction besides multiple myeloma, which is hypertension, diabetes, and sometimes, again, medication induced. So somebody got too high of a dose of a medication. And if you do have any kind of kidney involvement or impaired renal function, make sure that when you do get started on new medications, that those medications don't need to be dose adjusted for your impaired kidney function, especially antibiotics. A lot of antibiotics need to be dose adjusted based upon kidney involvement. Treatment for kidney function or kidney dysfunction is that we need to sometimes make sure that we stay hydrated. Sometimes we need to give IV fluids. We definitely want you to avoid the anti-inflammatory drugs such as Aleve, ibuprofen, Motrin, those types of drugs, because excessive use of those can actually affect the kidney function as well. Occasionally we have to do plasmapheresis, and occasionally we need to do dialysis. Unfortunately, if you get to the point where you need dialysis, hopefully it's not permanent dialysis. A lot of times we can get the disease under control and get the dialysis out of the picture. So, side effects for some of the commonly used drugs, Velcade being one of them. I'm sure most everybody in this room has heard Velcade can cause some peripheral neuropathy. There can sometimes be other causes for the peripheral neuropathy as well. Sometimes it can be that the actual monoclonal proteins are depositing on the nerve endings, and sometimes it can be due to drugs other than Velcade, such as vincristine or thalidomide. The symptoms of peripheral neuropathy can be that you have a weakness, so you notice that you're having difficulty opening a jar. You can have numbness and tingling in the hands or feet. Sometimes it feels like a burning sensation on the soles of your feet or in the soles of your hands. And it also can be to where you actually, your hand goes into like a claw kind of thing, or a cramping sensation. Treatment for the peripheral neuropathy can be, obviously, we want you to do some proper foot care and make sure that you're, wearing comfortable shoes and supportive shoes. But we also want to treat the underlying cause for the peripheral neuropathy. So in some cases, it's treating the myeloma. In other cases, it's actually maybe having to consider some dose reductions on the medicine that we think may be the culprit to the neuropathy. And in some cases, you may actually need to see a neurologist. And we also may use some of the medications such as Cymbalta, Lyrica, and sometimes some topical ointments or creams can help with that. I know some patients who've had some customized creams developed that have included things like lidocaine and other ingredients. So some of the common effects or side effects of the drug Revlimid can be fatigue. You can have some diarrhea, again, some muscle cramping, and you can develop a rash. So to deal with the fatigue, again, you may need to speak with your doctor about potential dose reduction, but also you need to force yourself to try and stay a little active. Sometimes if you give in to the fatigue, that just worsens it, so you do need to force yourself sometimes to take that walk up the block. And again, balanced diet, good sleep habits. Yeah, right, with dexamethasone on board, we got good sleep habits. But that's what the recommendations are for the diarrhea. Obviously, we want you to stay hydrated because, again, depending upon the severity of the diarrhea, you can cause yourself to be dehydrated, so we need to keep fluids in the mix. We also can use antidiarrheals, medications such as Imodium, Lomotil, and use those medications to keep it under control. The muscle cramping, you may want to do some massaging and stretching, but you may also want to use some tonic water at bedtime. And again, make sure that you're hydrated, that the cause is not due to a disbalance in electrolytes. And for the rash, we recommend that you use, you can use like topical hydrocortisone or Benadryl cream, and you can also take like an oral Benadryl or Zyrtec to help manage the rash. If the rash is severe enough, you may also need to go see a dermatologist to make sure that it's not something other than medication related. So one of the other drugs that's used in multiple myelomas is the Kyprolis or carfilzomib. And the common side effects to this medication, again, is fatigue, but also sometimes a little bit of difficulty in breathing and a drop in blood counts as well. One of the more serious effects that can happen, it's not frequent, but there can be some heart and lung toxicities. If you are concerned, the things you should be looking for are shortness of breath, chest pain, elevated blood pressure, headaches. And if you're having any of those, you need to make sure that your physician knows that. And we may refer you to a pulmonologist. Prior to starting this medication, or we evaluate whether you have a history of cardiac issues, and if so, we may get a baseline echocardiogram so that while you're receiving this medication, and should any symptoms occur, we have a baseline to compare it to. Hypertension, not only with this drug, but in myeloma in general, some of the medications can cause some additional hypertension, so we may need to work closely with your cardiologist and adjust medications. And we also would recommend considering a dose reduction perhaps in the medication if the symptoms don't improve. So dexamethasone, our lovely friend dexamethasone. The most common and most complained about side effect is the insomnia and the fluid retention and the mood changes and the dyspepsia or heartburn, and again, elevation in glucose. For the insomnia, again, in some cases, we've recommended patients to take the dexamethasone at night, especially if they're using it in combination with a drug like Revlimid or thalidomide or Pomalyst, because those drugs have a little bit of a sedative effect to them as well. And so sometimes if you take the dexamethasone when you go to bed, you're falling asleep, you've also taken the Revlimid, and then it takes about 4 to 6 hours before the dexamethasone kicks in, and then you wake up and you're ready to go. For fluid retention, we sometimes patients will do some diuretics. We use those sparingly, but we do monitor, and if the fluid retention is too severe, obviously dose reductions or possibly changing to a different steroid. Mood changes, irritability, anxiety, in some occasions, just downright aggressive, bad behavior. So again, we might need to consider switching to a different steroid or eliminating the steroids or dose reducing the steroids altogether. Whenever you're taking a steroid, we recommend that you take some kind of an antacid, such as a Zantac or a Tagamet or a Prilosec over the counter, just because steroids can do a number on the stomach and we don't want you to develop any kind of ulcers. And then for patients who may have an elevation in glucose, especially if you have a history of diabetes, you'll need to be able to work with your internist in possibly dose adjusting your medications on the days that you take your steroids or your insulin. And if you're not a diabetic, you may have to go on some kind of medication while you're on the steroids in order to be able to keep your blood sugars intact. So, lifestyle enhancements that we recommend: eat better, get more exercise, regular sleep, decrease alcohol consumption, give up tobacco, minimize or eliminate stress in your life. Yes, I have cancer. I can minimize stress in my life, right? But again, just trying to live a healthy, balanced lifestyle is the biggest recommendation. So in summary, there are various approaches to be able to reduce the impact of common side effects of multiple myeloma, such as the bone damage and the low blood counts and the reduced kidney function. And can't stress enough as myeloma patients that you need to keep yourself hydrated. Sometimes you can overdo it too, though, but just make sure that you're keeping yourselves hydrated, and make sure that you work with your doctors and your nurses. Don't not tell them about something that's going on that you think is minimal, because one, they can't help you if they don't know about it, and two, that it may be minimal, but if it doesn't get, the sooner they know about it, the sooner we can make sure it doesn't get worse as far as neuropathy and, bleeding, all of those sorts of things. And with that, I thank you.
So I'm going to ask you two things that we often do in clinic, but they are questions from the audience. How about pickle juice for muscle cramps? Does it work for people? And what about the role of alpha-lipoic acid for neuropathy?
I didn't mention it, but yes, we do have a lot of patients who, what's the term I'm looking for, just out of habit, have tried some of our non-proven methods, but a lot of people do say that pickle juice helps them, especially if they take it at night prior to going to bed, if the cramp, because sometimes for some people the cramping seems to occur more at night. What's in the pickle juice, as far as just probably all those electrolytes, the sodiums and the calciums and that sort of stuff, which is just beefing you up that you have a good electrolyte balance. So some people just eat the pickle before going to bed. Some people have a little bit of the pickle juice like a shot. And another one that some people have used for cramps has been the yellow mustard. I have one patient who keeps little packets of yellow mustard like you get when you're at the hot dog stand, and when he's having the cramp, just opens the packet, sucks out the yellow mustard, and says that helps him as well. As far as alpha-lipoic acid, we do, especially if we know someone is starting a medication that can cause peripheral neuropathy, such as Revlimid or Velcade or thalidomide, we do recommend that they start out on an alpha-lipoic acid, 600 milligrams once a day. And if they start that prior to, hopefully that prevents the peripheral neuropathy from occurring. If the peripheral neuropathy does occur, sometimes we can increase that up to 1,800 milligrams a day and get the peripheral neuropathy to where it's manageable for them and not interfering or painful. The one thing we definitely get concerned about with peripheral neuropathy is you do not want it to become painful peripheral neuropathy, because that affects your quality of life.
One other question. Mm-hmm. What do you do with patients with kidney problems with bone drugs?
With kidney problems with bone drugs?
With bone drugs.
Okay.
Bisphosphonates et al.
Again, depending upon the severity of the kidney function, we may not give the bisphosphonate at all. In other cases, we sometimes give the bisphosphonate longer. So zoledronic acid we may give over 3 hours, or in some cases an hour. In some cases, we may switch to Iridia and give it to over, the standard 2 hours to 3 hours for Iridia. But it doesn't keep us necessarily from giving the drug, but we do make sure prior to each and every bisphosphonate infusion that we check creatinine levels. And if there has been any kind of a bump in that creatinine level, we obviously discuss that with the physician, and in some cases we, again, hold the drug, and in other cases we just give it over a longer period of time.
We do have another option, though, now, Xgeva, for those folks who have kidney problems, which looks just as effective as zoledronic acid or Zometa. So that is now an option. And that does not cause kidney problems.